Okay, so that was an example of electronic health records being very useful to investigate a safety signal. Now, so investigating safety signals and drug utilisation are things that we've been using these data for years. So I want to then move on to what I see as the future in using real-world data and evidence for pharmacoepi research. So starting with safety signal detection. Now you know from the last talk that one area where we use spontaneous reports is to develop hypotheses of drug safety signals, and we're very used to doing this using disproportionality. But the question is whether or not we might also use the electronic health records themselves to generate signals. And I'm not going to go into detail on the methodology, but just to give you a flavour, there's a partnership from a few years ago called OMOP, the Observational Medical Outcomes Partnership, and this was a large public-private partnership that was led out of the US, and it looked at healthcare databases and how we could use them better to study the effects of medicines. There's a great website which I've given you details of there, where you can find more information about what they did. But what they did was looked at whether or not we could use electronic health records to look for signals of adverse reactions to do with vaccines. And then more recently, we've also done some work looking at whether we might use them to investigate the effects of non-vaccine medications. And much of the methodology is around the use of self-controlled methods, which I'm not going to go into detail on now, but I will tell you more about on Friday. Okay. And moving on to, there was a paper published back in January by Jesse Franklin from Harvard. And I think this is a really nice summary of where we are at the moment in terms of real-world evidence and where it can be used and where we are still trying to develop the methodologies. So there's the safety bit at the bottom here, which I've just been talking to you about, where we know that we can use real-world evidence to look at the effects of medications. But what's really interesting is this bit here, where we wonder how and if we can use real-world evidence to investigate the intended effectiveness of treatments. So you've got here, we're going to talk in a minute about historical controls. You've also got the idea of secondary indications, so whether or not once the drug is approved and it's then on the marketplace, can we ever use real-world data to approve indication extensions? So for example, could we extend an indication to children even though they weren't studied in the randomized trials, purely based on real-world data? And I would say at the minute the answer to this question is not known, but there's the potential that we could. And then there are also what we call adaptive pathways. And examples of this might be where there's a high unmet medical need, and so a treatment is given a license quite early on, perhaps because it's shown an effect on a biomarker, when what we really care about is a clinical endpoint. And so whether or not once the drug has been approved, we can then use real-world evidence to supplement what we know from the trials to look further at clinical endpoints. So I think all of these are quite interesting, and I would suggest that if you're interested in this, read this paper. It's a really well-written paper that talks about the future of where we might go. But I'm also going to talk a little bit about where we are, or where I think we are, in electronic health records for effectiveness. So it's built into the legislation in the European Union, at least, and in some other regions, that knowing about treatment effectiveness is very important, and that we can insist that companies do studies to look at effectiveness in routine usage. Whether or not we can rely on observational data to do this is an unanswered question. And whether or not there's too much confounding in observational data is uncertain. And I would say, if it's possible for us ever to do this, it might be in quite limited circumstances. I don't think there's ever going to be a wholesale move to investigating effectiveness in routine care data. But we're still trying to decide if and when we might do it at all. Having said that, there is the possibility of actually randomising within routine care data. So the idea of pragmatic trials was raised quite early on, where we might want to know, within just normal care usage, if I randomise people to one treatment versus another, what will happen? What will their outcomes be? And that this might be quite different to what we see in the pre-marketing explanatory trials, where everything's perfect, where care is perfect. We pick our patients because they've got no other diseases, no other medications, and we see our perfect efficacy. But there's no reason why we can't just randomise people in routine care to also receive a treatment. And I'm going to move on slightly. One of the things that we can take advantage of is the fact that doctors themselves can act a little bit randomly. Now, it isn't always clear to a doctor when you might give one treatment versus another. Maybe there's no good reason why, if you've got a patient with type 2 diabetes and they've already tried one treatment, why would you give them the new treatment versus a sulfonylurea or an SGLT2 inhibitor? How would you choose between them? Well, sometimes they don't know. So in fact, it's possible that you could take advantage of that indecision and just randomise people to one or another treatment. So it's harnessing uncertainty that already exists clinically and then making better use of that to be able to then determine the real effects of treatments. Here's a trial that was done a few years ago within the clinical practice research data link. And the idea was that it was a pilot for future trials, just to show that this was a possible thing to do within the database. And it was basically looking at randomising people to either atorvastatin or simvastatin. So the patient definitely needed a statin, and then the GP could randomise them to one of these two statins, which you would think was a fairly simple thing to do, a fairly simple thing to get agreement on, and that the regulatory hurdles would be low in order to do this kind of study. The way it worked was, if the patient was in a GP practice and the GP was about to prescribe either atorvastatin or simvastatin for the first time ever to that patient, there would be a screen that popped up on their prescribing terminal to say, this person could be in our randomised trial, do you want to recruit them? The GP gets to decide, I'm a bit busy, no, go away, or yes, this looks possible, I'll talk to the patient, we might recruit the patient into this trial. And then the beauty is that the system would then randomise the patient to one of the two statins, the doctor would make the prescription, and then nobody would ever need to do anything else for the trial in the future, because all we would do is simply collect the information from the electronic health record as it happens. So it wouldn't rely on the doctor filling out forms or remembering to do something. In fact, we wouldn't want them to do anything different for that patient. Just prescribe the treatment and just follow them up as you would normally. Okay, that's the beauty of this. Would then generate real evidence of what happens in routine care when a patient takes one treatment versus another. Yeah? So it sounds nice and simple. Sounds like it should have been easy. But in fact, what happened was there was a massive dropout rate. So there were 459 individual primary care practices that agreed or that were contacted to see if they would like to be in this study. Over 80% returned the letter to at least say whether or not they were interested. So 18% didn't even reply. 58% said that they were interested in being a part of this kind of study. So that's quite good. The problem is, as they went down all of these regulatory hurdles that they had to go through simply to prescribe either atorvastatin or simvastatin in the context of it being randomised, meant that they mostly dropped out. And we thought this was fascinating, that you take a very non-controversial question like atorvastatin or simvastatin, and suddenly you find yourself in a position where everybody in the practice has to be given good clinical practice training for being in a trial. Well, the GP's just deciding for themselves normally whether to prescribe atorvastatin or simvastatin. Nobody insists on coming to give them any training when they make the decision. But if they roll a dice, then you have to give them all this training. So what the investigators found quite depressingly was that in the end, only 17 practices out of originally 459 were able to recruit any patients. So the main reasons that they gave as reasons why they stopped taking part were the time and workload for the clinician. It was just too much, and the ethical and regulatory approval needed seemed unnecessary for this kind of research. So there's a lot to do in terms of having this kind of process embedded within a health system, but I am still quite hopeful that there will be progress, but just to say it's not there yet. Okay, and then moving on to a study that I'm involved with, again in the CPRD, where we're looking at the real-world effects of medications for chronic obstructive pulmonary disease. And this is the published protocol, and we're trying to use the electronic health records to answer a question about effectiveness, but using the results of a randomised trial to validate our findings. Okay, and the way that this works is that we start off with a real randomised trial that was done some years ago, and we already know the results. We can access the individual patient data for that trial. There's a website that you can apply to called clinicalstudydatarequest.com, and you simply ask them, you tell them what your research question is, and they grant you access to the data. So having got those individual patients, what we then do is go to the CPRD and find patients who look as similar as possible to each of those patients in the trial. We then look within those patients who are very similar to the trial population to see if we measure the effectiveness of COPD treatments amongst our CPRD electronic health record population, do we get a result which is similar to what they found in the randomised trial? And if the answer to that is yes, we see a similar result, then our next step would be to ask questions about the sorts of patients who were not included in the trial, maybe because they were too old, or they had more severe COPD, or whatever the reason was, and then try to estimate the effectiveness of COPD treatments in those patients, given that those are clinically interesting questions where we don't know the answer. Okay, so we're still working through this study. We are currently at this point, and all I can say is things are looking good so far. So we'll see how we get on with this section of the study next. But it's another potential way of using the electronic health records to try to estimate treatment effectiveness. My question, which I still remain with, is will anybody ever believe the answers that we get from a non-randomized comparison of these records of treatments? And I don't know the answer to that. You might have your thoughts. I'm skeptical as to how often we will believe the results, but I'm open to possibilities. But it is, like I say, it is very much where we are in terms of methodological development right now. Okay. I think there are some ways that we can think of approaching it. So we can compare our results with trials, where trials are already available. We can have control outcomes or exposures, a little bit like we had with the malignant melanoma study. So within the data, asking the question, what do we know to be true already, and which we could demonstrate with the data? And then the last thing we can do is something called quantitative bias analysis, where we take our results that we generate within the observational data and we ask a question of, if there was a confounder that we were missing, or a series of confounders that we miss, how strong would they need to be to explain away the result that we have? And if the answer is, well, if you'd have just had slightly better control for confounding, you would have had a null result, then I won't believe my results very well. If the answer is, you would need to have an enormous amount of confounding to change the results that you generated, then I may have more confidence that my results are correct. But these are things that I think we need to do, but I think we still don't have a good idea how best to do them and how best to interpret them.